Going on, everybody? Read it. Clean off my desk a little bit. Yeah, let me clean off my desk a little bit. Hope everybody's doing well. Okay, I think I'm ready to start. How's it going, everybody? Today, our discussion is on negative symptoms, particularly negative symptoms in schizophrenia. Now, we can trace the symptoms of schizophrenia back to a network referred to as the mesocortical pathway. Overactivity or hyperactivity of the mesocortical pathway is associated with positive symptoms of schizophrenia. Let's look at some of those positive symptoms here. Let's see here. Let's see. Name the positive symptoms of schizophrenia. And again, do I have to sign in for this? Well, I think I used up my my free subscription, my free things. Let me go here. Okay, I don't want, stay signed out. Yeah, I don't want anything free. Okay, how about explain? Explain the positive symptoms of schizophrenia. Oh, it's not available. Okay, it's not available. Okay, we should be able to get them real quick. I'm gonna accept this. Okay. Positive symptoms reflect hyperactivity in that mesolimbic pathway. And hyperactivity and the positive symptoms are typically auditory hallucinations, delusions, or disorganized thoughts or behaviors. And the hallucinations can be either auditory or visual. They can also be tactile. The delusions can be bizarre delusions for things that are just absolutely not possible at all. Versus non-bizarre delusions, meaning it's a possibility, but probably not likely. So hallucination, delusion, and then disorganized thoughts or behaviors. Sometimes the person cannot express their thoughts in a coherent and logical manner. Sometimes they won't be able to filter their thoughts, and so things come out at the same time. And so the thought process, the structure of the thought is disrupted, and you sort of listen to it and it sounds disorganized. So the positive symptoms reflect hyperactivity in the mesocortical pathway, and it can result in hallucinations, delusions, or disorganization, right? Now, the hyperactivity occurs because you have excessive dopaminergic activity. Yep. Excessive dopaminergic activity is the too much dopamine story that drives this entire issue. Let me show you what is happening at. It's taking place here at the synaptic cleft. Right here. Let me see if we can find it here. Right here. I hope I can blow this up. Yep. Great. Here's one brain cell, and here's another one. This is the presynaptic cell, and let's say this is the postsynaptic cell. Well, actually, the receptors are on this side, so I guess this would be the presynaptic since the receptors over here, and this would be the postsynaptic. Okay, if this is a presynaptic cell, then dopamine is released from the presynaptic cell into the synaptic cleft, and it binds to a receptor on the postsynaptic cell. Remember, this is a G protein. So when this cell G protein complex is activated, it sends instructions to the cell body to produce things, right? Likely more of itself. So the increased binding of dopamine to the postsynaptic receptor creates more dopamine that's eventually stored in vesicles, and they wait for the next release, right? So can you see this feed-forward process whereby dopamine is excreted from the presynaptic cell, it goes across the cleft, it binds to this postsynaptic cell, and eventually results in the production of more dopamine that's stored at the end of that cell to that postsynaptic cell to get ready for the next signal to be released. When this process is turned up, you get hyperactivity on that network, and therefore you get hyperactivity in the mesocortical pathway, right? And then you get the emergence of the hallucinations, the delusion, or the disorganized behavior. Does that make sense? But it's all a dopamine hyperactivity story. Now, this discussion is about negative symptoms of schizophrenia. And what am I saying with negative? This flushing out of dopamine from the presynaptic cell only lasts for so long and it poops out. When there's no more dopamine, the whole network becomes hyper, it starts to slow down. And because you're in a relative depletion of dopamine, everything becomes hypoactive. Now, in the presynaptic cell, there's no more dopamine to be released. And therefore, there's less dopamine in the synaptic cleft, meaning there's less dopamine binding to the postsynaptic receptors, meaning that less activity across the entire mesocortical pathway. Dopamine hypoactivity is the results in hypoactivity in the mesocortical pathway. And when we get hypoactivity in the mesocortical pathway, we get a certain cluster of symptoms associated with that. Let me look here and see if I can find the list. So list the negative symptoms of schizophrenia. Please. Glad I got an AI back. Okay. The negative symptoms of schizophrenia are a loss or deficit of normal behaviors or abilities, distinguishing them from positive symptoms, which are in excess or distortion of normal function. Remember, think of it turned up to the radio turned up too high, too much excitation, noise. First thing that goes down are your sensory experiences. Start seeing things that's not there. Next thing goes, start believing things. And then after that, you start sort of becoming disorganized. So you keep turning the thing up until the things fall apart, right? Ride till the wheels fall off, I guess that's called. And so the exact opposite, hypoactivity, are a lack of symptoms, right? A lack of symptoms. Okay, look at here. Okay, this is interesting. They can be divided into two main categories: diminished expressions and amotivation. Yeah, let me see what this says here. This may be interesting. I think I want to get the free stuff. I want the free stuff. I want to go ahead and get the free stuff and get on out. Symptoms of schizophrenia. Okay, positive. We remember the excessive amount of hallucinations and delusion, and then they just have disorganized behavior here. Okay, positive disorganized symptoms. Okay, disorganized thought. Yep, disorganized speech here. Yeah, disorganized thought. Disorganized behavior. Negative symptoms. Look, poverty of speech. Right. Flat affect, not moving much. Right. Poor attention, meaning not as aware. Look. Loss of motivation. Remember that mesolimbic pathway is the reward center, right? And many times, if you have a hypoactive mesocortical pathway, if you have dopamine deficient If you're dopamine deficient, that means that all the pathways that's dependent upon dopamine will be hypoactive. So that means your mesocortical pathway will have the negative symptoms of schizophrenia, right? The mesolimbic pathway is your reward system. So when they take cocaine and it causes the release of the presynaptic dopamine, it gives the high and everything, but then there's a burnout. And then when the mesolimbic system, mesolimbic pathway is hypoactive, then no interest, no motivation. Look, loss of interest, lack of motivation, loss of drive, sort of like apathy, look, lack of pleasure, right? That's the exact opposite of the mesolimbic pathway. Lack of social attention deficit, yeah. And so these are the negative symptoms of schizophrenia, and if you think of it, if the mesolimbic pathways are hypoactive due to very little dopamine, then that means that the person's brain is simply not producing enough of the materials it needs to sort of run the network well. That makes sense? So there's like a deficit. So you need to produce things, right? So if you're not having enough dopamine, you need to produce things. So you need to get instructions to the cell body to start producing these things in order to get your appropriate neurotransmitter levels to run these networks appropriately. Hope that makes sense. Okay, so remember, Haldol blocks dopamine receptors, right? And so why would you give a antipsychotic medication to a person who's having negative symptoms if the assumption is it's a hypodopaminergic state? So if they don't have enough dopamine, you mean you're going to block more dopamine receptors? Hey, we'll go through that over. It's a concept called modulation. They're modulators. So it's a different class of receptors, and we'll sort of go through that a little later. But let me go through, do a literature review on the treatment of negative symptoms. And to be honest, I always feel not uncomfortable. I always feel nervous. It takes so long for these symptoms to improve. It's like you kind of want to have some control over the process, and you don't know how long it's going to go on. And so I wanted to just go, express that there are some conditions that I do treat as a physician, and you're going to encounter these too as a physician, that you sort of need to go back to the literature and sort of keep looking at this thing over and over and everything until you get here's 20-something years and still look at negative symptoms with a lot of respect and regard, because it takes a while for these symptoms to improve. The positive symptoms can improve right away because you're just blocking the hyperactive networks. You're just blocking everything and taking up the seats on the train, right? So that you can't fill up. And so blocking is easy. And so that's when you get resolution of the positive symptoms a lot easier. But the negative symptoms, you may have to produce things, a lot of things. And that's the hard part. So let me go to Google Scholar here. So the pharmacological treatment of negative symptoms of schizophrenia. Let me just look at a few articles. Look, drug treatment of negative schizophrenia. Okay, pharmacological treatment. Okay, pharmacological treatment. Okay, systemic review, pharmacological treatment. Okay. Addressing the unmet need of patients with persistent negative symptoms of schizophrenia, emerging psychological treatment option. Okay, so let me see here. Okay. Remember, we getting free. Getting free. Jump it in, jump it out. Okay, let me see here. Drug treatment of the negative symptoms of schizophrenia. The traditional antipsychotics are generally poorly effective or ineffective against negative symptoms of schizophrenia, and are also associated with extensive side effects, which can themselves cause or exacerbate secondary negative symptomatology. Wow. Yeah. This seems like it expressed all my fears, all my, as well as having a low propensity to cause EPS. All right. The currently available putative or typical antipsychotic clozapine, Risperdal, yep, well, okay, yep. Developmental antipsychotics, okay, and low dose of certain traditional antipsychotics, okay, have been reported to ameliorate negative symptoms and compare it with placebo. Okay, okay, some of these have been shown to be effective. Okay, they have been reported to ameliorate negative symptoms in comparison with placebo or standard. Okay, all right, so, okay, although, okay, to date, few trials have specifically examined the primary negative symptomatology, and it has been suggested that the improvements observed in these drugs may be related to a decrease in positive symptoms and a reduction in EPS symptoms. Hold on a second. Okay, let me see here. Okay, to date, a few trials have specifically examined primary negative symptomatology. Okay, right. And it has been suggested that the improvements observed with these drugs may be related to decrease in positive symptoms and or reduction in sedation or EPS side effects. Oh, wow. Okay. So basically, yeah, you're reducing side effects and EPS symptoms. Has, um, although a typicality has been ascribed to 5-HTD2 antagonism, the exact pharmacological mechanism underlying the efficacy of the atypical antipsychotics have not been elucidated. I thought it was. Okay, well, anyway. All right, let me just go to what their findings are. Okay, conclusions. Okay, the use of low dose antipsychotics and negative symptoms. Okay, although in the majority of studies, the classical antipsychotics had low efficacy against negative symptomatology. Reports over the last 10 years have suggested that they may have been more effective at low doses. This is consistent with animal studies' facilitation of dopaminergic transmission at low doses compared to inhibition at higher doses currently used clinically. Among the drugs for which a good dissociation between dose stimulation and blocking dopaminergic transmission has, I don't know what it says there. So saying low dose is the pharmacology of atypical. Yeah, because remember they have that broader receptor profile, receptor binding profile. Several theories have been put forward to explain both the improved tolerability and efficacy of atypical antipsychotics against negative symptoms, and the combination of the anti-serotonergic component with dopamine antagonism. Yeah, was first proposed in 1989, which one of the widely quoted. However, the effects on the neurotransmitter also be important in the clinical profile of the atypical antipsychotics, that these are different between. Okay. Here, the results of the trials of antipsychotics discussed above suggest that these drugs are superior to traditional antipsychotics in the treatment of negative symptoms. So yeah, we were typically using the typical antipsychotics like Haldol or some things like that for the negative symptoms, but they're saying atypical dose and low doses. However, since negative symptoms may be secondary to EPS symptoms, positive symptomatology, depression, or sedation, and in the majority of trials, such as secondary negative symptoms were not differentiated from the primary negative symptoms of disease. I didn't know there was a primary and secondary. I didn't know there was a primary and secondary negative symptoms. So, so I guess they're saying that the patient present with psychomotor slowing, psychomotor retardation, and things like that. It may be a more complicated story because they could be having side effects to the medications. It could be extrapyramidal side effects where they're having movement disorders that's produced by the treatment. And so I think they're saying that low-dose antipsychotics may ameliorate some of those symptoms, and therefore it may appear as if the patient's negative symptoms improve, and really you're just getting rid of the side effects of other medications. That's very interesting to know. Let's say, although it has been claimed that the newer atypical antipsychotics have improved efficacy against the negative symptoms of schizophrenia when compared with standard antipsychotics, evidence for an effect independent of an improvement in positive symptomatology and of EPS symptoms is poor, right? The pharmacological profile responsible for improvement in efficacy has not been elucidated, but it is certainly likely that the only one receptor but it seems unlikely that only one receptor subtype mediates all the atypical effects, meaning that the neurotransmitters responsible for creating this are probably a combination of not just one neurotransmitter. So let me see here. Pharmacological treatment of negative symptoms schizophrenia here. Pharmacological treatment of negative symptoms schizophrenia, therapeutic opportunity or cul-de-sac. Okay. Negative symptoms of schizophrenia are debilitating, and they contribute to poor outcomes in schizophrenia, right? Initial enthusiasm that second-generation antipsychotics will prove to be powerful agents to improve negative symptoms have given way to relative pessimism that the effects of current psychological treatment are at best modest. So they're saying that they overstated the efficacy of the atypical antipsychotics and low dose particularly, and treating negative symptoms. Okay, the method, a review of current state of play of pharmacological treatment for negative symptoms of schizophrenia. Treatment results today have been largely disappointing. The evidence for efficacy of second generation psychotics is reviewed. Conclusion, the measurement and treatment trials methodology for the evaluation of negative symptoms need additional refinement before therapeutic optimism that better treatments for negative symptoms can be realized. You see how, it's amazing how they say basically they say it don't work. They're saying the evaluation needs additional refinement before therapeutic optimism that better treatments for negative symptoms can be realized. It's interesting how they said that. Negative symptoms are disabling, difficult to evaluate. Difficult to evaluate. Treatment thus far have, at best, modest impact upon negative symptoms, especially for primary negative symptoms. I think it's probably a good idea to start explaining this more, using more education to sort of explain this, because looking at this literature, again, I think I'm not the only one having challenges with treating negative symptoms. So introduction. Negative symptoms of schizophrenia are core components of schizophrenia that unfortunately remains largely recalcitrant to current treatments. Yep. So here, what are negative symptoms? Dysfunction of communication, alogia, poverty of speech, talks little, uses few words. Look, dysfunction of affect, blunted affect, reduced range of emotions, perceptions, experience, expressions, feels numb or empty inside, recalls few emotional experiences, or feel good, bad, feels good or bad. Either good or bad. Let me explain something here. Look at this blunted affect here. So it not only has to do more with your facial expressions, like here, your expressions here. It also has to do with like your perception, right? Look, your experience, right? You ever been engaging with someone and they're simply locked in a certain perspective, right? They're locked on a certain focus. That's that not only is the facial expression may be limited, but their ability to jump off the subject may be eliminated. they may not be able to jump off the subject because they have that restricted affect, and so they can only recall restricted experiences or have restricted certain types of behaviors. So they can only engage with you in a certain restricted way. You see, someone who's been traumatized can only engage with you in a traumatic way until they find some way to recover from that. Does that make sense? It's not like someone who's traumatized treats you with kindness, and it seems like they're in the crisis, and it's simply that anger, the energy is typically directed at outward at the time. So here, look, dysfunction and socialization, asociality, reduced social drive and interactions, little sexual interest through friends, little interest in spending time with others. Yeah. Dysfunctional capacity for pleasure, anhedonia, reduced ability to express pleasure. Right? Dysfunctional motivation, avolition, reduced desire, motivation, persistence, reduced ability to undertake and completely take any new allergies. Okay, so let me see their conclusion. Okay, what was their conclusion? Let me see here. Okay, they basically the study says that there's really not enough evidence that says atypicals work better than typicals, so you should just be careful with it. Pharmacological treatment of negative symptoms. Let me see here. Okay. So pharmacological treatment. Effective treatment of negative symptoms is one of the most important unmet needs in schizophrenic disorder. Yeah, because the evidence of current psychopharmacological treatment is unclear, because the evidence on current psychopharmacological treatment is unclear. The author reviewed the findings published to date by searching PubMed with the keyword negative symptoms. And that's the end of that. That's the end of that article. It's free, you know. So we're here at the 27-minute mark. I think that's all I have for now. I think you get the point. You get the point. Hey, iHash, how you going, buddy? So let me see here. Okay. How's it going for you, iHash? Thanks for the comment, buddy. Which rating scales and bedside assessments are most practical in outpatient settings? I use the Schizophrenia Assessment of Negative Symptoms scale. It's called the SANS, SANS. And it has all of those domains we talked about. Yeah, I wish I could show you now, but I don't have. Let me see. Yeah, I can go over here. Symptoms. Yeah. Okay, scale for assessment of negative symptoms. Yeah. So this is the scale that I use here, right? Okay. Do they have the actual scale here? Yeah. So the scale basically causes you to rate things in these 5 areas. And so that's what I use for it. You see. Okay. And I think that's all I have for today. All right. So if you have any other questions for me, feel free to like, subscribe, and share, or put the question in the comment section. I'll see if I can get back to you with you. Reed, it's a pleasure talking to you guys. Take care, guys. Ciao.